bring you guys in because I want to point out some of these structures for the respiratory system. And I'm sure a lot of this is going to be repetition. Okay, we've got that common passageway, the pharynx, and the nasopharynx, the oropharynx, and the laryngopharynx are going to be that common tube until it splits or bifurcates into the trachea and the esophagus. Esophagus, of course, being posterior. Okay, I'm going to buzz through this because I'm assuming this is pretty much review for you guys, right? It's going to bifurcate, the main bronchus is going to bifurcate into the right and the left. Okay, right is going to be more vertical, so we tend to aspirate into that side, right? Is this all ringing a bell? Going to break down into bronchioles. Then it's going to break down into those alveoli. Now, a couple of things to keep in mind, of course, is that we've got the cartilaginous rings. I'm going to go through all this. I'm doing a once over, okay? Cartilaginous rings that make up the trachea. I also want to talk to you about the epithelium, which is going to be the cells that line the respiratory tract, because that's where we get a lot of disease processes begin to happen, okay? So we're going to look at the bringing in of the air, how we bring the air in, which muscles help to contribute to that process, which muscles force the air out, and all those pleural pressures, okay? The pressure inside of the lungs, the pleural membranes. We're going to talk about all of that. Now, if you look at the lungs, we've got two pleural membranes. And the pleural membranes are going to be a layer of cells that will cover on the lung itself and then a layer on the chest wall. And they abut each other. They touch each other. These serous, remember they're serous membranes, okay? Now, the main reason that we have these serous membranes is, first of all, it provides separation of cavities, right? Okay, and kind of like God's plan or whoever you believe in was sort of to segment these cavities, so if infection were to set in, guess what? It mostly stays there, okay? But the other reason is if you put your hands together and you rub them really fast, you're creating friction, right? Serous membranes, if they did not have serous fluid between them, it would be awfully painful and you would have quite a bit of friction. So that layer of cells on the lungs and that layer of cells on the chest wall touch each other, and they secrete that serous fluid into that space in between them. Okay, and it's just a film. It's just a film or a membrane. It's not a ton like we would see in a fusion. Okay. Respiration, the act of breathing of ventilation, okay? So 3 different types of respiration, though. We have external, which is going to be obvious, right? External is going to be the exchange of air from the external environment to the internal environment. Now let's review one concept here. Am I going too fast? Okay. One important concept here is the exchange of air is due to a change of pressures, okay? Exactly. If you decrease the pressure within the lung by expanding it, air will flow in. This is a passive process. If you compress the chest, you'll force that air out. That's your external respiration, okay? So the actual physical act of bringing air in and out. And of course, this gets inhibited, doesn't it, with some people, and we'll go over all those, yeah, those restrictives and obstructive diseases. Then if you can imagine the alveoli, and I have a picture of this, okay, we're going to go through it. The alveoli are little clusters of grapes. Let me see if I have a picture of the alveoli. I'm going to zoom ahead. I know that I have a picture of it. It's a little bit further along. There we go. Okay, so you can see these little alveoli are like clusters of grapes on this stem. They're very thin-walled. They're 1 cell thick, so we can have a good exchange of gases across that membrane, okay? And they're surrounded immediately by pulmonary capillaries, okay? So we can have that nice exchange. This, guys, is where our internal respiration happens. The movement of gases across these membranes from a high to a low pressure is internal respiration. Okay, so internal respiration is movement of gases from high to low pressure across the alveolar and the pulmonary capillary membranes. Okay. And of course, oxygen is going to be highest in the alveoli. So it's going to move from the alveoli into the blood. Carbon dioxide is going to be highest in the blood, in those pulmonary capillaries, and it's going to push its way into the alveoli and then be expired. Okay? Breathe nice fresh air. Oxygen in, goes across that membrane to the blood. Carbon dioxide is exchanged because that's actually one of the main drivers for pushing oxygen onto a hemoglobin unit. Okay? That carbon dioxide moves to the alveoli and we breathe it out. Okay? Internal respiration. Now, I'm going to go way back to the beginning because we're right here. Cellular respiration. Did I just feel everybody's skin crawl? Do you guys remember cellular respiration? Cellular respiration is when we bring oxygen in to be used with glucose in the Krebs cycle. Okay? Citric acid cycle is another word that we can use for that as well. Okay? And that Krebs cycle is inside of cells. When we bring glucose and oxygen and put them together, the Krebs cycle is going to create energy. Okay? Through a whole series of crazy steps, you eventually get approximately 36 little units of energy called ATP. And one of the byproducts is carbon dioxide. Bammo. There we go. That's where we get our carbon dioxide from. So let me run through it one more time. You bring air in. The oxygen comes in through an inhalation. It crosses the alveolar and the pulmonary capillary membranes, gets into the blood. Carbon dioxide will leave the blood, go into the alveolar opening, and then be expired. Okay, so do we get that little series? Now, once we have oxygen in the bloodstream, oxygen goes to every tissue in the body, every cell in the body. It'll enter those cells of the body with glucose. Combined together, they go through that Krebs cycle. You don't even need to know that. Just know that glucose and oxygen will create energy in the form of ATP, and one of the byproducts is carbon dioxide. So now we have carbon dioxide in the tissues, so we need to get rid of it, right? Put it back into the bloodstream. It actually is converted into something else, which we'll get into. But let's just say carbon dioxide travels back to the lungs, and then we breathe it out. Okay? So we need this oxygen to make energy. That's the whole gist of it. So if we get a break in that system anywhere, that's going to be a problem. Okay? Respiratory system, upper and lower respiratory tracts. Okay? Upper respiratory system, so nasopharynx and sinuses, and there's 4 groupings of sinuses, okay? Frontal and maxillary, I'm sure we remember, right? Above and below the eyes, which are totally congested on me. I have a little bit of a head cold. But deep, do you remember the ethmoid and the sphenoidal ones that are deep in the brain? So people at home, I'm sure you guys know this, but I just want to cover all my bases. We got all frontal and maxillary, those are the killers, right? But deep in about here, we have sphenoidal, and a little bit in front of that, we have ethmoidal. And those are deeper sinuses, and all of them help to lighten the skull. And they also contribute, especially these 2 groupings, contribute to warming and humidifying the air. So we get air coming in, and it kind of, circulates through those sinuses, gets warmed, gets humidified before it goes down into our lungs, okay? Now there's 3 parts to the nasopharynx. Behind the nose is nasopharynx, behind the oral cavity is oropharynx, and behind the larynx, which is our voice box, is the laryngopharynx. That's going to be a common tube. By that I mean we're going to have food, water, as well as air pass through those passages before they take a turn to either go to the stomach or to, the lungs, okay? Now cilia, we're going to have cilia that'll line the respiratory tract, okay, from the trachea down, and it starts to, what happens I'm going to explain to you what the epithelium is first. Let me get to that, but we have cilia that line most of the cells of the respiratory tract. And as we get down to the alveoli, there's kind of this smooth transition from tall columnar cells, are called pseudostratified ciliate columnar. Do you guys remember that? No, okay, I'll go over. But on top of those pseudostratified is the cilia. And those cilia are what help to force substances out of the respiratory tract, because that would be bad, right? If it got lodged in there for many reasons. And what it does is kind of gross, forces it up and into our GI tract, and we ingest it. Sometimes you can spit it out, right? Okay, if stuff comes up, you feel it come up, you can spit it out. But our nasal hairs are also cilia. I mean, I lived in London for a summer. Every time I got off the tube, the subway, I blow my nose, right? And the cilia, the hairs in my nose, would catch a lot of that, whatever it was, besides gross, okay? So, and the other thing, of course, is the ear draining into the middle ear draining into the posterior of the nasopharynx, okay? That keeps that middle ear open. That is the tube that we pop if we go in an airplane, okay? And what that does is it balances the pressure between your middle ear and your external environment, okay? So our upper respiratory system. Okay, frontal bone, I just want to show you, there is a frontal bone, and it's right here, okay, that hard part. But the rest, as I play with my nose, you can see is going to be cartilaginous, okay? Island cartilage. That's why, did you ever see those pictures of Michael Jackson as he was getting, did you see when, I don't know if it was real or if it was Photoshop, but they had it down where he'd like lost all the cartilage, and oh. So all you could see were those, those turbinates, those round structures in the back of the nose of the bone. So, one nose job is generally enough in life, right? You don't want your nose falling off. That's right. Supposedly he had a prosthetic nose. That's what it was, and he would take it out. I don't know if that's real or not, but now you remember that that's cartilage down there, and the nasal bone is actually up here. Okay, my son, not the one I sent you a picture of, my older son actually cracked this. I have so many damages for my kids, but anyway, love them anyway. So that's what I wanted you to see. I don't want you to know all these individual names. I want you to see that nasal bone, where it's located, okay? And they're tiny. Those nasal bones are tiny. There's 2 of them. They're only 1/2 an inch and 1/4 of an inch wide, give or take. The rest is cartilage, okay? And then here's all the parts. I think this would be a good review. Oh, people at home, I'm sorry, let me bring you in. Okay. So a good review of all these structures. This is a great picture of working from the top to bottom. You can see the sphenoidal sinus. So I'm working at the top. In the front is the frontal sinus. A little bit further back, you can see that sphenoidal sinus. Okay. You can see the nasopharynx, the conchae, which are going to be these little turbinate structures that help to create volatility in the air as it comes in. So it circles through that area and warms a little bit, okay? You can see the opening for the pharyngeotympanic tube towards the back, opening up in the posterior of the nasopharynx, okay? Now in children, of course, we know that they're going to be more horizontal, and you can tell as you grow, they're going to become more vertical and drain better, but that's where it's going to open back there. Oropharynx is going to be the opening in the posterior of the throat, and just behind the voice box is going to be the laryngopharynx, okay? You can see the epiglottis here too. I think that's a great picture of the epiglottis, and the epiglottis, of course, we know is going to close off that respiratory tract if we inhale things or ingest things. The uvula is part of the soft palate. While we're here, let's review that. That's going to go up when a patient swallows, okay, and it closes off the nasopharynx. Unless you have a friend in high school who used to spit milk out of his nose and had control over it, okay, most of us don't, and that's going to close that off. Just underneath that epiglottis is going to be the glottis, okay, also known as the vocal cords. There's a true and a false. I don't know what the false does, I'll be honest with you. But the true is the bottom one, and that's what bangs together when we create our vocal speech, okay? And then we could see the different rings of the trachea, okay? 3 parts of the, did I go backwards? I thought I already had this picture. No, I'm going in order, okay. The 3 different parts of the pharynx there, okay? So larynx is going to be our voice box. It's at the top of the trachea, okay? Then it's going to break down to bronchi, bronchioles, and alveoli. Okay. Now, the thing that I think I will point out now while we're here. Okay, I know we know all those structures, but what I want to talk about is the transition from the trachea to alveoli. Okay, so we've got trachea, we've got the bronchi, okay, bronchioles, and alveoli. The trachea, so I want to talk about just a couple of the structural attributes of these. Can't see anything. I was going to try to lecture without my glasses. Let me put my glasses. Because I can't tell if that writing is big enough for people at home. Okay. So, what I think is important, well, I think everything is important to remember, but what I think is important to remember about the trachea is two things. It's going to have pseudo stratified, everybody cringing, columnar, oh, sorry, I forgot a word. Let me know what the word is. Pseudostratified begins with a C-I-L-I-A, cilia, pseudostratified ciliated columnar. It has a pseudostratified ciliated columnar. Pseudo, like false, P-S-E-U-D-O. Stratified, layers, strata. Pseudostratified ciliated columnar. I have a picture of this, so I'll describe what it looks like to you. What I want you to really understand is basically they're columnar-shaped cells with cilia on top. And cilia, we know, are those little motile structures which help to filter substances that get stuck in that mucosal blanket up and out and either into the GI tract, or like people can spit it up too. Okay, so the cilia and the fact that they're columnar cells is what's important for you to remember. The other thing about the trachea, and you probably already know this, is that it's going to have those cartilaginous rings. Okay, it's going to have C-shaped cartilaginous rings. This, I'm not going to have enough room. All right. So C-shaped cartilaginous rings. Okay. So those are two important things that'll come into play as we move along. Bronchi are more or less similar, okay, to the trachea. It's going to have this pseudostratified. It may start to approach a shorter appearance. Okay, there'll still be cilia. You may start to lose some of that. As you start to move into bronchioles, they'll get even shorter, and they'll start to get into what are called almost these squamous shape or these egg-shaped cells that line, okay, the inside. And by the time you get to the alveoli, you're going to have what's called a simple squamous layer of cells. And once again, I have pictures. Okay. Okay. And these simple squamous. So if I were to take, you know, like 10 eggs and just break them open and they were kind of all different amorphous shapes, that's what squamous cells look like. And in the alveoli, there's a layer, simple layer, which means one, simple layer of squamous, or these egg-shaped cells. Now that makes sense, right? Because we're going to have a lot of transition of gases across these membranes, okay? You don't want it as thick as those columnar like we see in the trachea, because it'll be harder to get substances across. You want it nice and thin, okay? So in the alveoli. So it's a transition from the trachea down to the alveoli with that lining epithelium, and that lining epithelium is going to be those closely packed cells of the columnar cells in the trachea and the squamous cells in the alveoli. But the other thing is, as we move down, we're going to lose that cartilage, aren't we? Okay, so by the time we get down to, you're going to have cartilage in the bronchi. Bronchioles is hit or miss. Okay, it depends on whether it's a respiratory bronchiole or not. It's getting a little, I don't know. You can note if you want to. But you start to lose the cartilage in the bronchioles. You may see chunks of it here and there. By the alveoli, you don't want any cartilage at all, right? Because you want a quick transition into those pulmonary capillaries. That's important to know too. So as you're moving down, you're going to lose the cartilage because you're moving from a structure that's trying to hold the trachea in place down to something that you're trying to pass gas. Okay, pass gases across. Okay. Now, there's one other thing. Bronchioles. Bronchioles, guys, this is where we have our smooth muscle. Okay. Smooth muscle, as you remember, is involuntary, and smooth muscle will be around hollow organs per se. Okay, I don't want to confuse you because I mean this isn't a whole organ itself, but hollow tubes. Let's put it that way. Blood vessels, bronchioles, GI tract. Okay, so smooth muscle is part of the autonomic or automatic nervous system. Okay, we're going to have smooth muscle around these bronchioles, and guess what gets affected here? Guess who? I have it, and I take an inhaler for it, and it affects the smooth muscles in my bronchioles. Asthma, okay? So asthma, this is where it happens at these bronchioles, okay? So, wow, I just went over a whole lot, but that's good. We'll get through all this with some review and some pictures. Okay, so lower respiratory system. So larynx, okay, is your voice box. I'm going to buzz through this stuff. You guys should know this. Helps to keep the food from the lungs because of the epiglottis. This is where the vocal cords are. There's true and there's false ones. Again, I don't know if the false just provide a site for attachment of ligaments. They don't look like they do anything from the dissections I've seen. I'm not sure. But anyway, the true are going to cause the tone of our voice. They actually bang together. Okay. Here's a nice picture of those cartilages. Okay, you can see the thyroid cartilage there, the cricoid cartilage underneath it, and then those tracheal rings. Okay, and then the hyoid bone, which is up above. And we know that the thyroid cartilage is the Adam's apple, right? So it's going to be bigger in males than it is in females. Okay, here's a nice side view. So posterior, as you're looking at this picture, guys, would be to the left. Anterior would be to the front. And you can see that epiglottis, the false and the true vocal cords. I think this is a great picture of this on the inside, okay? Larynx. The other thing that can happen at the larynx, I think that this is important. You know, this is going to be where Valsalva's maneuver is performed. Well, not performed, but you know what I mean, part of what contributes to it. So that glottis or those true vocal cords will close, and the patient will perform a Valsalva's maneuver against that closed glottis. What that does is it increases intra-abdominal pressure. Okay, people do this when they defecate. Okay, yeah, it's fun. We talked about poop and A&P on Monday as well. They didn't laugh as much as you though. Intra-abdominal pressure will rise, which makes sense because we got to push the poop out, right? So it helps that happen. My 5-year-old does this. It cracks me up. You could see him. You could see him like really forcing, bearing down. Okay. People also do this during heavy lifting. And what does this contribute to sometimes? People do this Valsalva's maneuver. They lift something really heavy. They hear a pop and they do what? Blow a disc, right? Because they increase that intra-abdominal pressure, pushes back on those discs. That disc is ready to go, you know, pushes it through the last few fibers. So, Valsalva's maneuver. Valsalva's maneuver can also do what? Can drop blood pressure, right? So you guys know that. I don't need to explain that to you. But there's the mechanisms of what actually happens, okay? Glottis, another word for the true vocal cords, closes, abdominal muscles contract, intra-abdominal pressure rises, helps to empty the rectum, or stabilizes during heavy lifting, okay? You can also use this as an orthopedic test. If somebody has blown a disc, you can ask them to bear down. They always look at you funny, but you know what I do? I do it with them, okay? I'm gonna ask you to bear down, hold your breath, and pretend like you're having a bowel movement, okay? And I do it with them, and that makes them feel more comfortable. But man, if they got a blown disc, bam, yeah, it flares it right up. And you know immediately that it's probably a blown disc, okay? Because that pressure, let me take it one step further, that's inflamed, that disc is highly inflamed, puts pressure on that disc, which pushes it out further on the nerve. The nerve is inflamed, right? And you're gonna create an antegrade movement along that nerve, creating a lot of pain and discomfort. And I want to go off topic a little bit here right now. Discs, when you look at discs, the nucleus pulposus, this is totally off track. So if you guys don't want to listen, that's totally cool. But I think this is kind of interesting. The discs of the spine. When you herniate a disc, the inner portion, the nucleus pulposus, the gelatinous part is enclosed when our immune system is forming. So when people blow a disc, they blow out that material. Our immune system doesn't recognize it. That's why they get so much inflammation with the herniated disc. Isn't that cool? Well, it's not cool, but it's a cool physiological mechanism, okay? So, side note, extra, got you a little extra for your money, okay? Trachea, we know this, right? Larynx is gonna lead to the bronchi. We're gonna have those C-shaped, I'm sorry, my phone's ringing. No phones during class. They just got a little distracted. Okay, mucus is released from the epithelium of the trachea, which is gonna be, once again, that pseudostratified ciliated columnar, okay? And that mucus is gonna do what? It's gonna provide a mucus blanket, which is gonna help to trap particles, okay? Help to protect. On the back part, the trachea, let me see if I have a picture of this. Sorry, as I'm panning through, I hope I'm not making you dizzy. On the back part of the trachea, we've got, oh, here it is. This is a good picture for it, okay? So we've got only C-shaped rings in the trachea. They're hyaline cartilage. There are, gosh, 10 to 12 of them, I believe. Is that right? And then the carina at the bottom. On the back part of that C-shaped hyaline cartilage is the trachealis muscle, which can provide a little bit of contraction or dilation of that trachea. Minimal, okay? This isn't major movement. So you can see this is a lateral view. It's like we've taken a sagittal section through that voice box, and you can see those cartilaginous rings with this smooth muscle in the back there, okay? So that's called trachealis muscle. Okay, contracts during coughing to help expel that mucus. The last tracheal cartilage, which I think it's right where the bronchi pair off, and in one of our stupors one night trying to memorize all this stuff, first of all, it looks like a pair of panties. I'm not even joking. Sorry, I'm backing up. Okay, there it is. You can see at the bottom of the trachea, you can see that carina. It looks like a pair of tighty whities, okay, if you look at it closer. And I always remembered it because of that My Sharona song. We were up late, really late one night. I couldn't remember of it. My roommate's like, no, I wasn't drinking, I swear. My roommate's like, my carina. You remember that song? Anyway, I'll play the song and break. So there's the carina there. That's where it bifurcates, okay? And splits down to those two primary main bronchi. I took cold medication